Hello to everybody just coming in. Welcome. As people get settled in, I'd like to invite you to tell us a little bit about yourself. If you'd like to tell us your job role, maybe your work sector, the region that you're coming from. The chat feature will be open throughout our time together this evening. My name is Jen Calver. I am the Program Manager of Research with WeRPN. And joining me this evening is my colleague, Norma Tomlin. She is a Director of Professional Practice at WeRPN, and Dr. Emily King, who is our guest presenter, and I'll be giving a more detailed introduction as we move forward. The format of our session this evening is going to be very open. We're going to share some of the latest research that has been coming out around responding to workplace violence and harassment reports. We do ask that everybody check that their microphones are muted to prevent any background noise from disrupting the speaker. But if we have those areas that really resonate with us or moments that we don't want to forget or we want to connect with one another, the Q&A and chat features are available for you to add your questions, comments. We can share links and resources. You are absolutely welcome to do that. And then we're going to have an opportunity to really dive in further to these ideas in smaller breakout groups. So the main session will be recorded. We like to share the presentation with you and upload it to our library for future references. I will note that those small breakout sessions will not be recorded, and this is to provide that safe space to be able to navigate some of these difficult conversations or maybe uncomfortable conversations. And that brings us to our disclaimer. So our presentation this evening does include discussions of workplace violence, harassment, and related experiences that some participants may find potentially distressing or triggering. So with that, we do encourage you to take care of your well-being during this session. So if at any time you would like to step away, you can mute your audio or turn off your video at any time. We do encourage everyone to access support resources that are available either through your workplace, your community, or professional supports. And we've included some resources and links at the end of this presentation. And just a reminder, participation is voluntary, and there's no expectation to share any personal experiences. And we'd like to thank you for prioritizing your well-being and engaging in this important conversation with us. With that, I will turn the slides over to Norma to share our land acknowledgement.
Thanks, Jen. So as a virtual gathering, we acknowledge that WeRPN's home office is located on the traditional territories of the Mississaugas of the Credit, the Haudenosaunee, the Haudenosaunee, and the Huron-Wendat peoples. This land is covered by Treaty 13, an agreement intended to reflect peace and partnership, though it was not always honored in that way. We recognized in the enduring presence and contributions of the Indigenous people who continue to care for this land. As nurses, we acknowledge the colonial health systems have caused real harm to Indigenous communities. In 2025, the Canadian Federation of Nurses Unions apologized for care that was denied, trust that was broken, and lives that were lost. Reconciliation in nursing calls us to practice with humility, provide culturally safe care, and to take responsibility through our everyday actions. Let this acknowledgement not only words, but commitment that it carries into our practice, our advocacy, and our relationships. Mi Jawan, Ni Awen, and Shaka. Thank you.
Thank you, Norma. So WeRPN is the professional association for RPNs, and the mission is to break down barriers raise each other up, and collaboratively enhance the difference RPNs can make across the health system. And part of our strategy at WeRPN is to drive evidence and increase representation of RPNs in research. And so our presentation this evening ties into the research priorities that were brought forward to us by RPNs and the broader research community. And we look at workforce development and health and safety for RPNs. Workplace violence continues to be a critical issue for nurses in the workplace. Each year, WeRPN conducts a survey with RPNs to really understand their experiences and what's happening in this evolving healthcare landscape, if you will. And the respondents to the survey told us that more than half were continuing to experience violence in their workplace. And they felt that this had been an increase in violence compared to the previous year. And they were noting that their supports that they can go to some of the more experienced nurses to consult on more complex cases and patient care was actually becoming less and less as we were seeing more experienced nurses leaving the workplace. The last few years, I've been looking at workforce retention through my growing research program. And in 2022, I was awarded a RPN Research Fellowship, where I looked at staffing stability in long-term care. And one of the key themes that I wanted to share with you this evening was around rebuilding healthy workplace through enhanced leadership and organizational support. And so the staff from long-term care homes told us that they really wanted support with in assistance with conflict resolution for addressing work issues. And they really wanted their organizations to protect the staff from abuse and noted that unaddressed work concerns lead to tension. Later on, we continued to build on this study, and we worked with long-term care leaders from across the province to understand those elements of psychological health and safety for workforce retention. And these leaders identified 45 consensus priorities for psychological health and safety and retention, and they very much aligned with the staff insights. So they saw it being very important that everyone felt supported in their workplace, that they had organizational controls in place for violence prevention, physical protection, and psychological protection. And that brings us to our guest this evening, who's going to share their research on reporting workplace violence and harassment as part of the job. I'm so pleased to introduce Dr. Emily King, who is a director of research at VHA Home HealthCare. A major focus of her current research is on opportunities to improve safety and quality of work life for home and community care providers. This includes workplace violence and harassment. Dr. King holds a master's and doctoral degree from the University of Toronto. She is an assistant professor in the Division of Occupational and Environmental Health at the University of Toronto Dalai Lama School of Public Health, and she is an adjunct assistant professor at the University of Waterloo School of Public Health Sciences. And so with that, Emily, I will turn it over to you.
And thank you for coming to listen this evening and to participate this evening. The work that I'd like to share with you is work that we've been doing at VHA Home HealthCare on improving the ease of reporting workplace violence and harassment, and looking at how we respond to workplace violence and harassment reports. And I'm hoping that our focus today can be on what those responses look like. So I'm going to provide you with context on the program that we've developed and some of the sticky bits around responses that have emerged. And I'm really looking forward to learning from your insights on that as well. So the work that I'll present today next slide, please, Jen, is the product of a large team's work. So we have many members of our research team, as well as our operations and human resources teams who've played leadership roles in developing this reporting and response framework that I'll share, and in bringing it to life and implementing it at the organization. The work has been largely done internally by VHA and has had some funding support from WeRPN. Thank you. from the Center for Research Expertise in Occupational Disease and from a CIHR Health System Impact Fellowship. So next slide, please. Yeah. So I think the baseline, Jen has set us up really nicely. Thank you, Jen. The baseline that we're working from is that across sectors, healthcare workers often experience, unfortunately, high rates of workplace violence and harassment, that there is a culture of normalization and toleration of the harassment and violence, as has been really emphasized through the recent Ontario Nurses Association bus stop ads campaign that I'm sure that you've seen. And there is a pervasive culture of underreporting across sectors, across health professions, that makes it difficult to know the true rates of violence and harassment that are experienced, that makes it difficult for supervisors, organizations, and peers to provide support and to help to tackle some of the root causes to reduce the incidence of workplace violence and harassment. And we know that hopefully, usually what people would consider the major incidents are reported, the ones that lead to more serious injuries. But we know that even the small stuff that people experience on a day-to-day basis hurts and builds up and affects quality of work life, affects people's psychological well-being, affects their ability to do their jobs, and ultimately also impacts patient care. And so even the small stuff is a problem. And so next slide, please. We at VHA are trying to promote the idea and to shift the culture towards saying that accepting violence and harassment is not part of the job. Reporting it is, and reporting it can improve safety for colleagues and care for clients. Next slide. And for it to do that, it does matter how we respond when people report. The way leaders and organizations respond to those reports needs to validate the choice to report and to encourage future reports. And that's why our focus today is more on the responses. So next, please. So when we set out to design a new reporting and response system, the goal was to tackle a lot of the traditional barriers to reporting. So reporting takes too long and I don't have the time. Okay, reporting needs to be quick. It doesn't matter. Nothing will change. Reporting needs to be meaningful. People will think if I report that I somehow can't handle it, can't hack it. Reporting needs to lead to not blaming the worker for what happened. And because I'm doing this work in a home care context where the dominant compensation model is pay per visit, we need to make sure that people aren't losing income because of their choice to report. So reporting has to be quick, meaningful, and not lead to blaming the worker or reducing their income. And then the response focus has to be on providing support for the person who chose to report and respecting their preferences where possible. So we focused on a trauma and violence informed approach that recognizes that the same set of events can have very different impacts on different individuals, and that just by knowing the set of events, you can't tell how it will have affected an individual because you have a different background and history than they do. Often there is a desire to focus on restoring client relationships where possible. We've developed this system initially for use with personal support workers. And personal support workers in home care invest hugely in developing strong relationships with their clients and the clients' families, as do nurses in home care. And that is one of the next groups with whom we're sharing this. So there's a focus on restoring the client relationships where possible. And we recognize that a lot of violence and harassment has its roots in unmet needs. And those unmet needs may be on the part of the client and family, or they may be on the part of the reporter, and often both. So we have an emphasis on trying to identify and address those unmet needs for support that may be leading to the problematic situation. And so creating value in the reports and encouraging meaningfulness in the reports. We're trying to move to a situation where people don't think that accepting the violence and harassment is part of the job, but they do think that reporting it is, for the safety of their colleagues and for the quality of their clients' care. Next, please. And so this reporting and response system, we're taking a socio-technical system perspective. And so I'm presenting both the technical parts of the system and the social parts of the system. The technical parts are like where you enter your report and what is done with the information, and from like the technical workflow side. And then the social system is, how do the people around respond to that? How do the supervisors respond? How do your peers respond? What is, what's the human side of the response to those reports? And the goal is to bring these social and technical elements together in a way that makes the reporting feel both meaningful and safe. And so I'll talk you through briefly what that looks like in our implementation at VHA. And so on the technical side, the reporting needs to be quick, easy, and to occur in a familiar space. And so the reporting form that we've introduced is quick. 2 drop downs to say, what kind of incident was it? How easy was it to handle? 1 open text box to give a bit of information about what happened and provide any strategies for helping to manage it. So often people may not report because they've already dealt with it. Well, what about the next person? Will the next person know how to deal with it? So we're trying to provide an opportunity to share strategies. And then there's a radio selection. Do you want active follow-up from your supervisor, or would you rather minimize it? Because sometimes people don't report because they don't feel they need much support. Again, it's handled and they don't want to spend a lot more time on it. So we're trying to make not just the report, but the follow-up match the time commitment that people would like to have. So hopefully that's quick and easy. And then this takes place within a familiar context. And so this is within where they would do a normal end of visit documentation anyway. Now, for this to be meaningful, useful information also needs to be visible to the right people. So next, please, Jen. The last 5 reports are shown to other people who may visit this same client. And so that is known. And so people are entering only information they'd be comfortable with their peers seeing in this reporting form. But this is encouraging people to share for those, let's call it, the things that they may perceive as minor, that they may not previously have reported, where it's, for example, a responsive behavior that they have successfully de-escalated. This is a great place to share that this is something that can happen with this client, and this is a great strategy for managing it. Needs to be visible to supervisors. So our supervisors have access to a dashboard, Jen? Yeah, and notifications when there are incidents that affect their staff so that they can respond promptly, because the responses also need to be quick. And finally, senior leadership has visibility into the patterns in reporting through dashboards that have been created so that we can look at, are there areas where we're seeing an increased need for education around certain things? Are there areas where we might need to be, seeing additional needs for support related to certain clients or certain providers? So again, just an opportunity to monitor the patterns and make sure that everybody has visibility into this important aspect of safety. Okay, but then what we do with this matters, and that's where we get to the social system. And we know that the responses need to be non-punitive, which I've done with an asterisk here, because nobody intends the response to be punitive. But sometimes responses that are intended to be protective can have negative impacts for workers or for clients. And so, we know that there are some PSWs who choose not to report, violence and harassment related to responsive behaviors because they don't want the client to be punished because they're not as aware of their actions. So we need to make sure that there are supportive responses that support the client where needed and that support the reporter where needed. The responses need to be supportive, trauma and violence informed, and that needs to be conducted in a an appropriately sensitive way. And the responses need to be prompt. The response process needs to be transparent, and it needs to, where possible, respect worker choices as to the ways in which they would like to be supported. And so to do this, we, through co-design with personal support workers, their supervisors, our human resources for clients, union representatives, we developed a response framework that lays out how we would ideally respond to these situations, and that is available to our providers as well as to our supervisors. So it's very transparent as to the process that we're committing to and what people should expect. In some cases, it was necessary to update policies to ensure that, for example, if somebody is removed from a client's care due to concerns about violence and harassment, that those hours are prioritized for replacement so that they're not losing income. So that was the policy update, was the next pop-up, Jen. And then finally, to build a culture of collective responsibility for safety and to denormalize the workplace violence and harassment, we designed interactive education sessions, which were delivered to all of our personal support teams through over 50 trainings in classrooms, in parks, wherever they were, to share this new way of sharing, to share what people could expect when they reported, and to encourage people to report even the small stuff, because sometimes there's actually something that can be done to help. There may be behavioral supports. This may signal a need for a medication change for a client, depending on how something's emerging. There's information in that can be shared and can be acted upon. And so that was another critical element of this system. And so that's the system that we've put into place. It's been operational for well over a year at this point, about a year and a half. I'm happy to say that the majority of our PSWs are using the system. And they're using it sort of during the majority of opportunities through our reporting. I will say most of these reports say, nope, nothing happened, it was fine. But we know that reporting by exception in this means that we miss a lot. It's very different to say, no, it was fine, than it is to just not say anything, because often we know that just not saying anything doesn't mean it was fine. So next, please. When people do report that something happened, in terms of what they're sharing, the incident type is most commonly verbal aggression, which is not something we would always have heard about before. And is most commonly, next slide, please, Jen, and is most commonly easily managed. And again, those are things that we may not have heard about before. So we see evidence that this is increasing the flow of information that is predominantly used by and available to peers to know what is happening with a client when they go in to provide coverage, or when there are shared clients. Next, please. We know that in most cases, people are not requesting follow-up. So they are reporting for information and for the benefit of their peers rather than because they need a supervisor to help them with this. And in terms of the types of incidents that they're sharing, the kinds of precipitating incidents, next please. The most common contributors to verbal aggression, which is our most common report type, are people being frustrated related to out-of-scope requests or not being able to do something a client asks them to, resisting care or refusal of care, suspicion and accusations, frustration with scheduling, and substance use. These are the most common contributors to the verbal aggression reports. Next, please. For harassment, most commonly we're seeing sexual harassment. Next is racism, and finally, again, substance use as contributors. For contributors to violence, we are seeing sometimes this results from resisting care or refusal of care more aggressively. Sometimes a responsive behavior related to a medical condition, and sometimes declining a client's request. And you can see many of those items are similar to the ones that are triggering verbal aggression, but leading to a more serious outcome. Next, please. So it's not just about what the administrative data is telling us. It's also really important to understand what PSWs are experiencing when they report, and the supervisor experiences of responding. And I'll pause just to, I guess on the next slide, to say that we've done this through in-depth interviews, 40 in-depth interviews, 30 with personal support workers, a fairly representative group, the majority women, middle-aged, average age 43, from a broad range of ethnicities that's approximately representative of our PSW population at VHA, with a, on average, a reasonably experienced group, but ranging from, half a year to 24 years of experience at the time of the interview. Our supervisors, again, majority women, 32 to 55 years old, average 41. Again, a broad range of ethnicities, roughly representative of our supervisor population at VHA. They've been in their roles for an average of 3 years. 70% of them are RPNs. In addition to this, we had a child and youth worker and a registered nurse, and one person who chose not to share their qualifications. The average team size they're supporting is 60 personal support workers. So this is a large responsibility, large leadership responsibility. And the interviews for the PSWs lasted an average of half an hour and about 3/4 of an hour for the supervisor interviews. And so that's what I'm drawing on for the next few slides as I share some broad patterns, early insights that we are gaining from these interviews. In terms of the system, the reporting and response system, experiences varied. Some PSWs really trusted the system, liked how it was used, did indeed find it quick and easy, and found that the system is effective, it's responsive when the supervisor responds in a timely manner. So when the technical and the social elements work together, it's good. And we have a quote on the right-hand side of the slide there with somebody saying, yeah, they don't need to call the office. They just filled out a report on the streetcar while they were going to their next visit. Some people were unsure or didn't trust the system. Some weren't sure they trusted the technical side, and they used email or phone to dual report. So they would enter it in the system and then follow up by email or phone. And we did see some testing of the system to see that it worked. And that's reflective of the fact that these interviews were done about 9 months after the system was rolled out. So it was reflective of people's early experiences. And so it's, is the supervisor checking it? Will I get feedback? I don't know. So some early phase testing. Next, please. In terms of how the whole reporting experience and system affect people's choices to report, because I think that, that's a big driver here, is looking at, will people choose to share their experiences? Are we tackling the underreporting? Many PSWs are still selective about what they'll report, still reluctant to report dementia-related behaviors, not necessarily reporting repeat instances of the same behavior, and some are choosing still not to report the minor incidents. So our administrative data tells us that we do have a real uptick in people reporting the minor incidents, but it's still not everything. So we still know that what we're seeing is not fully representative of people's experiences. PSWs were sharing that, yes, they were reporting to provide safety information for their colleagues. So in terms of the collective responsibility for safety, that's a positive sign. Disincentives to reporting remained fear of losing income in a pay-per-visit model, being afraid that they would lose that client and lose the income. And if they had past experiences of what were for them not supportive leadership responses, that made them shy about reporting again. Next, please. So a couple of things to highlight. I won't read you all the quotes, but people choosing to report, is it minor? Is it major? That's one factor. In terms of collective responsibility, maybe one day I'm not there and they send a replacement. That could be a reason. But in terms of a non-supportive response, they may see, that's what the supervisors tell us. We're tough skin. You tough it out. It's not as easy as that. And that's it still hurts. And the subjective experience is still a problem. Which is why that trauma and violence informed approach really matters. Next, please. In terms of supervisors' response decisions, we saw that for the supervisors who were involved in co-designing the response framework, they did say their responses were guided by that framework. Most other people were still more comfortable with their intuition and previous experience as a guide for how they would respond. And a lot of the elements did align generally with the kind of approach laid out in our response framework. So they would gather detailed information and assess the impact on staff, albeit from the supervisor's perspective. They would tend to prioritize mediation, like reinforcing boundaries, coaching PSWs, having joint visits over staff removal. So that could be good if that aligns with the PSW's preferences. And they would tend to engage the funder early for clinical input and for planning resolutions. If the supervisor perceives the incident to be severe, which was especially common in cases of where sexual harassment was involved, they're more likely to go for an immediate protective response, which is remove the provider from care for that client to ensure safety and well-being. On the right, you'll see, so immediately once you tell me, I'm going to remove you. And I have removed the staff and we'll be putting in male staff, which is a common response in home care to cases where male clients are behaving in sexually inappropriate ways towards their female PSWs. Request funder support to implement protective measures. And so this is sort of a common type of response, although we do see variation. And we did see supervisors had different red lines in a sense, where they would see it as, okay, that was bad. We need to remove staff. Next, please. And so this brings us to, I guess, the practice challenge that we're seeing, which is, how serious is an incident? How serious is it from the reporter's perspective? How serious is it from the supervisor's perspective? Do these align? How do we respond in cases that these don't align, that there are differing perceptions of severity? In those cases, what is the appropriate response? Is the appropriate response, we're trying to build resilience? Is it, that wasn't that bad, and that's something you need to be able to handle? Is it, okay, if you say you can't go, you can't go? Where are the lines, and how do all the complexities of these situations need to be navigated? What does it look like to apply a trauma and violence informed approach, and how can we do it? And these are questions that have come out as we've been looking at evaluating our data related to the implementation of this system with personal support workers. We are also working on implementing a similar system with our nurses and our rehabilitation providers. And similar considerations will apply. And so I think that this is something that, this is about the human healthcare workers. It's not about their specific profession. And it's about the human leaders trying to do their best to manage all the pressures that they are facing. And in home healthcare, we know that the majority of care is provided by personal support workers supervised by nurses, and by nurses supervised by nurses. So this is a major nursing practice area. And the reason we set this up as a workshop, and something that I am hoping to unpack in the breakout room, is, what will good responses look like? How can leaders understand the impacts of these experiences on staff, and how this is going to affect the types of responses that will be needed? How might this be supported by or conflict with other supervisory responsibilities that they hold? And if there are any apparent conflicts or barriers to trauma and violence informed investigations and approaches, how can these be managed or reduced? So I'm hoping to work together to talk about what really good responses will look like and how to make that something that we can do. And so I think, Jen and Norma, you had something prepared here.
Thank you, Emily, for that. And to everybody who came on a Tuesday evening when it's cold and dark outside. Emily, that one slide you had earlier on that says accepting violence and harassment is not part of the job, but reporting it is. It really speaks to this conversation. And I'm really looking forward to hearing from everybody today to kind of navigate that. Because I'm thinking about times when I was in situations that I'll admit there was times where we normalized situations because we thought that it was part of the job. And it took a long time in my career to have space to start having these conversations that, we shouldn't be normalizing this. And that you mentioned it's not a conversation for blame. There's not really space for that. We're reporting it so we can get the supports in place so that we can get the proper procedures. But again, that punitive piece where we don't want anybody else to get in trouble and we don't want to get in trouble. So I'm happy that you brought that forward. I'm going to, I guess my question for this group is I can pause the recording for the breakout discussion and we can stay together as a whole group, or we can divide into two smaller groups. Does anybody have a preference?
This is a small enough group, we might all be able to stay together to
It might
have
be,
a fuller discussion together.
and I'm seeing no preference in the chat there. Okay. Well, let me pause the recording here and we can have our discussion and then we'll kind of summarize it. When we're ready to summarize it, I'll turn back on the recording. Summary? So thank you for the great discussions, everyone.
Yeah, and so we've heard, in terms of really the importance of pausing to be human first and to ask somebody when they report something, how are you? How has this affected you? Not expecting people to be, resilient in a way that means they're not impacted. Recognizing that violence and harassment and verbal aggression do have their impacts, and looking again at how we're defining resilience and what we're expecting from people. Really focusing first on humans, not the need to fill out a form as part of, a corporate responsibility. Having an emphasis on the skills that people are using in these challenging situations to de-escalate, to protect themselves, to ensure that the client is safe. And that, these creating a psychologically safe environment in which these conversations can happen can really help to identify where there are additional opportunities for education and training that can further support people to manage some of the challenging situations that we know will occur. I think those were many of the key elements that I heard. Norma, Jen, are there other pieces you wanted to raise?
I'm just bringing up remember to check in with one another, because that can unpack some of the skills that are hidden beneath or maybe normalized within the teamwork. I hope I translated that properly, but yeah, did anybody else want to join in? Okay. We like to take the last minute here just to provide an update of what's happening in the WeResearch programs at WeRPN. Thank you so much, Emily, for sharing your all the fantastic work your team is doing. We're going to keep following that. So for WeResearch, WeRPN has 6 studies that were funded in 2025 that are coming to a close. So we should be receiving the reports by July 30th, because they have 1 month after the projects close, and then we will provide updates on what emerges from those studies. Same with the RPN research fellowships. WeRPN offers research partnerships And those studies are continuing to go well. And from time to time, researchers will reach out to us and say, you know what, we really, really want to connect with RPNs. And so they have study invitations that are posted on the WeRPN research webpage. The link is there, and I'll share these slides with you. But if you check in from time to time, there might be an opportunity there for you that you're like, oh, this is something I really want to share my voice in, and the researchers will let you know the details of the study, the risk and the benefits, and answer any questions that you'll have, and all that information's there. We have some calls that are getting ready to close here at month end. So right now they are looking for 2026 research grant proposals, the 2026 RPN research fellowship proposals. And there's also a call out for anybody who might be interested in joining our research advisory council. There is a role for a public representative. So this is somebody who might not be an RPN, maybe they work closely with RPNs or are aware of what's happening with RPNs, an RPN representative, and then the academic university representative. The next WeResearch webinar is scheduled for June 16th. And here the researchers are going to talk about nursing scope of practice and professional collaboration. And this is a cross-provincial large 3-year study that has been going on. And so they're going to talk about what's emerging around RPNs in this area. And when you receive the slides, we have a list of supports here for you. So just in closing here, I do want to thank everybody for spending the hour with us. There's lots to conversations that can continue in this area. Lots of work still needs to be done to address some of these things that we're seeing and make sure that we're comfortable to build in those supports to increase that comfort for reporting and how to respond to reports without feeling that blame, or Emily, you used the word punitive earlier. And I do thank you for joining us, our conversation this evening.
Well, thanks for the opportunity to